Hello, doctors. I'm Dr. Chris Rapoff of DC QME Continuing Education. Welcome to this week's presentation. Now, in our careers as qualified medical evaluators, we perform several physical examination tests and maneuvers in the examination, including specific instrumentation use. Now, to those who have been performing these evaluations for several years, many of these steps of the physical examination come second nature to us, and as a result, we tend to go through the examination without consciously thinking about what we're actually doing. So today I wanted to review and remind you specifically of the examination procedures involved in the discovery of and the determination of peripheral nerve disorders and sensory loss. We'll specifically touch on the discussion of Sims-Weinstein monofilaments and two-point discrimination tools that we use in these exams. And finally, we'll touch on what the AMA Guides 5th edition has to say about when we use them, and in some cases, when these instruments are not required as part of the QME examination. I think you'll find this to be very informative and actually a bit surprising. So let's get started. First, these are the following sources that I referenced when producing this presentation. So in order to provide some context to this discussion, I thought we needed to clarify the difference between the term sensation and sensibility. Although they sound very similar, they actually are not. And the important difference between sensation and sensibility was actually very clearly defined by George Ulmer, MD, in 1974. Now, he is a former president of the American Orthopedic Association and an esteemed member and the former president of the American Society for Surgery of the Hand. Now, in 74, he determined that sensation is the acceptance and the activation of impulses in the afferent nerve fibers of the nervous system, whereas conversely, sensibility is the conscious appreciation and the interpretation of those stimuli that produce the sensation. He also mentioned that the palmar surfaces of the hand, or the digits, have a unique sensibility or capacity for the precise interpretation of sensation because of the dense population of the specialized receptor organs and the free nerve endings. The impairment evaluation of sensibility in the hand really then, therefore, deserves special attention. So today I wanted to address the impairment evaluation of sensibility losses in the digits and in the peripheral nervous system, specifically with the instruments used in a hand examination. So first, in the clinical evaluation, the evaluation of the sensory function in the hand considers all modalities of sensibility, including perception of pain, warmth, cold, and touch pressure, as well as vibration. Now, the grading system introduced by the Nerve Injuries Committee of the British Medical Research Council in 1954 actually described 6 levels of sensory recovery after a nerve injury. These levels are still used today to describe sensory changes. I want you to note what I highlighted as well, which we will talk about later in this presentation. First of all, SO is absent sensibility. S1, recovery of deep cutaneous pain and pressure sensibility. S2, return of some degree of superficial cutaneous pain and tactile sensibility and temperature appreciation. S3, return of superficial cutaneous pain and tactile sensibility. S3 plus, recovery of some of two-point discrimination. S4, complete sensory recovery. What's very interesting is generally if an individual has some light recognition in their examination, the sensory submodalities are assumed to be present. It's very interesting because if they feel it, you feel that they have a preserved level of sensation there. All the clinical tests that are used to examine the degree of functional loss of sensibility are actually related to the cutaneous touch pressure sensation. Currently, the two-point discrimination test for fine discrimination sensibility is the most widely used, and it's followed by the monofilament touch pressure threshold test. Interestingly, the Sims-Weinstein monofilament pressure aesthesiometer measures light touch and deep pressure thresholds with sufficient accuracy to quantify returning sensibility levels long before two-point discrimination is actually measurable. Now, the moving two-point discrimination test may be useful in evaluating recovering nerve function because the response to this stimulus returns before the response to a static two-point stimulus does. For example, the patterns of nerve loss and recovery seen in neuropathy or neuritis from a disease or a nerve compression are different from those following nerve lacerations or cuts. Within the limits of the current instruments, the two-point discrimination tests have been normal, whereas both Sims-Weinstein pressure aesthesiometer and nerve conduction studies have been abnormal in both clinical and induced neuropathies. Two-point discrimination does have the widest application for the individuals who've sustained nerve lacerations. Now, I'd actually like to discuss the procedure for using the Sims-Weinstein monofilaments. First, in preparation and testing, you ensure that the examinee is comfortable, their eyes are closed, and they focus on the sensation. You explain to them what the procedure is going to entail and ensure that they understand it. Then, as you test, you divide the palm into the hands of several areas, such as between the fingertips, the DIP joints, between the DIP joints and the PIP joints, and so on. And you test one point in each area. Now, the application of the procedure is that you use a set of monofilaments of different grams of force, starting with the lightest, which is usually the 2.83 grams. You hold the monofilament perpendicular to the skin, and you press the monofilament against the skin until it bends. You ask the patient or the examinee to indicate when they feel that the touch is by saying yes or they say touch. Now, recording these, if they feel that the monofilament, then you record the result. If they don't feel the monofilament, use the next thicker monofilament and repeat the process. You continue this process until the individual can feel a specific monofilament or until the thickest one is used. Now, in interpretation of these findings, you record the number of the monofilament that they can feel, and you use the interpretation scale to determine the level of sensation. And they go from green, blue, purple, red, and red-orange, depending upon the number of grams. Normal light touch perception of the green to the red-orange, which would be a deep pressure sensation only. Now I'd like to touch on the procedure for using the two-point discrimination test. First of all, in preparation and selection of the testing areas, you ensure them that they're comfortable and they do have their eyes closed and they focus on the sensation. You also explain this procedure to them so they understand what to expect. You do select the testing area by choosing the area on the body that you're going to test. If it's fingertips, palms, or other regions where the sensation needs to be evaluated. You ensure that the skin is clean, free of any barriers such as clothing or bandages. Now, the application of the procedure, you use a two-point discriminator tool or a caliper, whichever you choose, with the adjustable tips. You start with the wide distance between the 2 points, for example, 5 millimeters, and gradually decrease the sensation. You apply the 2 points simultaneously to the skin with equal pressure, and you ask them to identify whether they feel 1 or 2 points. Now, the method for testing is that you would randomly alternate between 1 point and 2 point applications to prevent the patient from guessing. Then you test each area multiple times to ensure the consistency and the accuracy of the responses. Then you respond by recording the smallest distance for which the individual can to distinguish between 1 and 2 points. And you repeat the test on the symmetrical areas on both sides of the body to compare the sensory function. And finally, in interpreting, you use the normative data to determine if the individual's 2-point discrimination ability falls within a normal range. Differences between the sides of the reduced ability to distinguish points may indicate some sensory nerve impairment or possibly another neurological condition. This is where it seems to get interesting. Now, when you're discussing peripheral nerve disorders and sensory loss and you refer to the AMA guides, it's really not clear from the text in the guides whether the use of the Sims-Weinstein monofilament test or the 2-point discrimination testing is mandatory. The Sims-Weinstein monofilament test is discussed on page 446, where much of this presentation has been taken from. However, on page 495, the Sims-Weinstein monofilament test is specifically mentioned, along with 2-point discrimination testing, when rating for carpal tunnel syndrome. It appears that at least when rating for carpal tunnel syndrome, chapter 16, the upper extremities, requires that both the Sims-Weinstein monofilament test and the 2-point discrimination test be performed. And as I mentioned on slide 4 above, there is only one reference in the guides specifically for the 2-point discrimination testing, and that is the grade 3 on table 1610 on page 482, which is used to determine sensory deficits, specifically mentioning the use of a 2-point discrimination testing, but not the Sims-Weinstein monofilament testing. So you can see there are some major differences in a lot of area that is open to interpretation by the examiner. Now, continuing on what the AMA Guides has to say about the use of these instruments, it's really kind of perplexing and sometimes confusing. Come to find out, we can actually do these peripheral nerve losses and sensory losses by way of 2 different chapters, chapter 13 or chapter 16, which is part of the upper extremities. Now, a physician may choose to evaluate the peripheral nerve injuries using chapter 13 rather than 16, and in that case, they would use table 1323 rather than the table 1610, which is the one that we use most often. And table 1323 does not even mention 2-point discrimination, and the Sims-Weinstein monofilament test is not discussed in 13 either. So even if both of the tests are determined to be mandatory in chapter 16 for these measurements, they're not mandated at all for use in chapter 13. So you as a QME should have and do have in your discretion the choice of these methods. Chapter 13, they provide examples and also the methods that are used by the physicians to determine sensory loss where pinpoint, cold, light touch, vibration, and joint positioning are used. Also, Jones, MD, who happens to be the chapter chair of Chapter 16 of the AMA Guides 5th edition, believes that the Sim-Weinstein monofilament test and the 2-point discrimination tests are really not required tests, except for rating digital nerve lesions, which requires the use of 2-point discrimination testing. Now, isn't that interesting? Have you noticed an instrument that has conspicuously been omitted in this section when we're discussing peripheral nerve loss and sensory loss? How about the Mortenberg pinwheel? The AMA Guides 5th edition actually does not specifically even mention the Wartenberg pinwheel because instead they're focusing on the standardized methods which have been widely validated and actually accepted in the medical community for evaluating sensory impairments. The guides also emphasize that the tools like the Sims-Weinstein monofilaments and the 2-point discriminators have been widely and extensively studied and shown to provide more reliable and reproducible results. On the contrary, the Wartenberg pinwheel, while we both know it's useful in our clinical practice, may not have the same level of standardization and validation as the other tools mentioned in the guides. So therefore, it's not even included in the official evaluation criteria. Well, there you have it. Today we discuss the significance of the various instruments, namely the Sims-Weinstein monofilaments and the two-point discrimination tool, as they help us in our assessment of the peripheral nerve disorders and sensory loss in the QME physical examination. We're also reminded, however, that the use of these tools, although they're discussed and explained in the AMA Guide's 5th edition, are not absolutely deemed necessary in all cases of determining sensory loss in the examinee. So, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you for taking the time to join me in this presentation. I hope you did enjoy it, and I look forward to sharing other interesting subjects with you as they relate to the workers' compensation system in the state of California. Until next time, thank you.